Now we're going to discuss about the different cancers of the skin. Again, very important topic for the exam. So I'm going to just give a rapid review of all the skin cancers which are like most important for your exam, including the basal cell carcinoma, squamous cell carcinoma, and melanoma. And let me start with the basal cell carcinoma. As you can see here, the basal cells, okay, basal cells are the part of dermis. As you can see it over here, basal cells, they are part of epidermis. Okay, they are like deep down near the epidermis. So basically, if there is any cancer which is involving, if there is any uh, unregulated division of the basal cells, eventually it results in the formation of basal cell carcinoma. Okay, basal cell carcinoma. So the first thing is that the basal cell carcinoma, it is what they say is most common skin malignancy. Okay, it's most common skin malignancy in the world. Okay, in the world. And if you have to remember one important point about the basal cell carcinoma is that it is found mostly in the sun exposed areas. Okay, sun exposed area. And the other important point is that what are the sun exposed areas? Okay, you can just identify it by yourself. It could be your face, either it could be nose, lips, and the scalp. Okay, uh, all these locations are the important as far as the basal cell carcinomas, because they are the most common sites where the basal cell carcinoma can be located, because basal cell carcinoma is seen at the locations at the sites where there is sun exposure, including face, including nose, lips, and the scalp. Okay, lips and the scalp. This is what you have to remember over here. After that, what are the clinical features? Okay, and one more important point among them, if you have to, if they ask you a direct question that most common location where, or in the clinical examination, they will just give you a case scenario where there will be a lesion near the nose, and you should remember that if there is lesion near the nose, the first differential should be the basal cell carcinoma, because the most common location, most common site for the basal cell carcinoma is none other than the nose. Now, what are the clinical features? Okay, clinical features of basal cell carcinoma. Remember that, once there is like this basal cell carcinoma, as you can see it over here, okay, there's unregulated division of the cells. The first initial lesion will be the formation of nodule. Okay, formation of nodule. Now, what is nodule? If you remember the basic definitions of the dermatology, we say that nodule is an elevation. It is an elevation, okay? It is an elevation of skin, okay? It is an elevation of skin which is more than 0.5 centimeter in height, okay? More than 0.5 centimeters in height. If you remember, if there is a lesion which is less than 0.5 centimeters in height, that is what we call as papule. Okay, papule, macules and the papules. Okay, papule is what, a lesion of the skin which is less than 0.5 centimeters. But in the basal cell carcinoma, this is the initially there is formation of a nodule just like this. Okay, if this is the nose, okay, if this is the nose, and here we can see there is a nodule, there is a nodule formation, and this nodule formation is what we call as a skin elevation of a height more than 0.5 centimeters. And if we go, if we zoom it over here, this nodule has very small, very, very small blood vessels in it. Okay, very small blood vessels in it, and the size, the size or they are very dilated. They are basically small dilated veins, and the size of these dilated veins are less than less than 1 mm. Okay, there are in this nodule there are dilated veins less than 1 mm. And if you remember the dilated veins, if you remember my lecture on the, uh, I guess, on the venous insufficiency, chronic venous insufficiency, over there I have told you the dilation of the veins based on the size. And if there is a dilation of the vein which is less than 1 mm, that is what we call as telangiectasia. Okay, so there are very small dilated veins inside it. They are what we call as telangiectasia. So basically, there are telangiectasia, dilated veins present in this nodule. Okay, present in this nodule. And sometimes what happens is that these blood vessels, they rupture. Okay, they rupture and result in the bleeding. Okay, bleeding, number one, and eventually there is formation of ulcer. Okay, there is formation of ulcer. There is formation of ulcer. So the important point is that in these nodules we have small dilated vein telangiectasia which bleed and eventually go deep inside and result in the formation of ulcer, which is what we call as a rodent ulcer. Okay, rodent ulcer. Okay, so it goes just like this. Okay, now this is ulcerative lesion over here, most commonly present near the at the site of nose. And if you look at the edges of, if you look at the edges of this lesion, they are what we call as beaded edges. Okay, beaded or rolled or pearly edges. Okay, they're basically shiny. They have a shiny appearance at the edge. And if we see any lesions over the nose, which looks like a nodule, ulcerative, beaded, or pearly or rolled with rolled edge, please remember that this is a basal cell carcinoma. Please remember that this is a basically your basal cell carcinoma. Clear? So if you are now, if you're now very clear with this very diagram and the other important concepts, then we can go back and look it over here. Basically, let me show you the picture. See, this is what we call as, if we can see it over here, the edges look like rolled. Okay, the patient has rolled. Okay, patient has rolled, or we can say pearly, or we can see it over here. They have beaded kind of appearance. And if we zoom it, if we zoom it, we can see it over here. We have small blood vessels. Okay, small blood vessels over here. And if you can see again, there is this ulceration, right? This is what we called as telangiectasia and ulceration. And this is what we know, that this is basal cell carcinoma. This is basal cell carcinoma. And tell me now the treatment of this. Okay, treatment of this. The treatment is none other than your simple elliptical excision. Okay, simple elliptical excision. If they talk about, we can say that this is basically your local excision. Sometimes they just don't mention about the simple elliptical excision. They will just tell you that okay, you can go for the local excision. And if they want you to if they want to test you about the margins which we take, it should be 3 to 4 mm margin. Okay, if for example, let me go back to the diagram. If I need to do the local excision of that this lesion, okay, I will take the margin. Okay, I will take the margin, and it should be like 3 to 4 mm. I will just measure this, and then I will take the excision, including 3 to 4 extended margin. Okay, 3 to 4 mm, 3 to 4 mm extended margin. This is the treatment of basal cell carcinoma. I hope this is very clear now in your mind. And sometimes if they want you to, if they test you about the prognosis, okay, we know they usually ask about the prognosis of the melanoma, but sometimes they ask about the prognosis of the basal cell carcinoma. Remember that the prognosis of basal cell carcinoma is given by, okay, given by important residual cancer cells in the margin of excised lesion. Okay, residual cancer cells in the margin of excised lesion is what gives us the prognosis for the basal cell carcinoma. And second one is the location, and the third one is architecture pattern. What is the shape of the lesion? So three prognosis. Remember that if you have to choose one, go for the residual cancer cells in the margin of excised lesion. This should be your answer. Okay, this is the answer for your the prognosis. What gives the prognosis for the basal cell carcinoma? Residual cancer cells in the margin of excised lesion. I hope this basal cell carcinoma is now clear to you. Okay, now we'll discuss about the squamous cell carcinoma. Okay, let's discuss about the squamous cell carcinoma, and then we talk about squamous cell carcinoma. Right, this is the second type of uh, cancer which is commonly seen uh, in the exam. So the important point which you should remember first is what are the pre-malignant lesions of squamous cell carcinoma, right? More importantly, you will see the questions about squamous cell carcinoma. The lesion would be present at the helix of the ear, right? So what are the pre-malignant lesions of the squamous cell carcinoma? It is keratoacanthoma. Okay, basically, there's in guidelines on the Dermanet, they say that keratoacanthoma, it is same as the squamous cell carcinoma. It is not the pre-malignant lesion, but a type of squamous cell carcinoma. Okay, a type of squamous cell carcinoma which arises from pilosebaceous gland. Okay, pilosebaceous gland. And after that, if they ask you about the uh, management part, you have to remember the shave biopsy can be used for the diagnosis. Okay, for the keratoacanthoma, it is mostly seen in the sun exposed areas, but remember that as a general rule, squamous cell carcinoma can be seen at the sites of sun exposed areas, or it can be seen at non sun exposed areas also. Okay, like the ear, as I said, and it's that is the most common location where you can find the squamous cell carcinoma. After that, what are the other pre-malignant lesions of squamous cell carcinoma? Marjolin's ulcer, which is basically a type of, again, a type of squamous cell carcinoma seen in burn patients. Then we have chronic ulcer and chronic radiation dermatitis, and that may also develop squamous cell carcinoma, leukoplakia, okay, which you see uh, in the tongue. Okay, the leukoplakia is most commonly seen in at the tongue side. So that's again a pre-malignant lesion of squamous cell carcinoma. Then we have solar keratosis. If you can see it over here, this is the keratosis is mostly seen in the sun exposed area and mostly at the back of the hand. Okay, as you can see it over here, this is pre-malignant lesion of squamous cell carcinoma. There's another pre-malignant lesion, or we say that it is basically a squamous cell carcinoma in situ. Okay, in situ, type, and that is Bowen's disease. Okay, in situ Bowen's disease, that is basically your squamous cell carcinoma in situ, that is Bowen's disease. You can see the everted edge, and in between there is an ulcer, as you can see it over here. They will give you a picture, and at the time you may get uh, confused between the solar keratosis and the Bowen's disease, but you can see it over here. There are ulcerative lesions in this Bowen's disease, and there is it is reddish and erythematous. Okay, again, shave biopsy is for the um, diagnosis, also the punch biopsies for the diagnosis. Surgical excision is the treatment. If they ask you about the surgical excision, remember that it is basically your elliptical surgical excision, taking a margin of 3 to 5 mm, taking a margin of 3 to 5 mm. And this is all about your squamous cell carcinoma. Please look at the images of squamous cell carcinoma. Let me show you one of the one of the image. You can see it over here on the dermanet. This is your squamous cell carcinoma of the face. Okay, squamous cell carcinoma of the face. Then we have another type of squamous cell carcinoma of the face, as you can see it over here. There is this is there is a debris or the keratin which has been accumulated over here. Then we have melanoma. Okay, melanoma. Remember, one question about the melanoma which has been asked in your exam is that uh, in order to prevent the melanoma, what is the advice which should be given to the general public? It is that please and please avoid direct sun exposure from 10 a.m. to 3 p.m. Okay, 10 a.m. to 3 p.m. This is what should be advised to the patient. And what is the pathophysiology? It's very simple. There is dysregulation, or there is a fast, unregulated uh, division, or the division of the melanocytes, which are responsible for the formation of melanin, which gives us the uh, brownish texture of the skin, and that prevents the cancer, that prevents our skin from the skin cancers. And but it itself can result in a cancer if there is unregulated division of the melanocytes, that results in the increased level of melanin deposition on the skin, and that is what we called as melanoma. Okay, melanocyte dysregulate and secrete increased melanin, resulting in the melanoma. Okay, early you diagnose it, that is good for the patient. And remember that this is your question for the exam, and this is the question for your exam. Thickness of the melanoma is what gives a prognosis. In your exam, they will just ask you about the prognosis of two things. One is basal cell carcinoma, another one is the melanoma. Most important to talk about the melanoma, and if they talk about what gives us the prognosis of the melanoma, that is none other than the thickness of the melanoma, and that is what we called as Breslow's thickness. Okay, Breslow's thickness. Please remember this about the melanoma. Prognosis given by the thickness of the melanoma, that is what we called as Breslow's thickness. More the thickness, that means it has invaded deep structures also. Okay, it has gone deep, that means that is the prognosis will be worst. More it is superficial, good is the prognosis. A very important sign is where we suspect that the patient may have the melanoma is change in the freckle or the mole. Okay, if there is change in the mole, where we use a criteria of A, B, C, D, E, where we use a criteria of A, B, C, D, E. A is your asymmetry, B is the border, C is the color, D is the diameter, E is the evolution. Okay, if uh, so the question is, where do you suspect that the patient may have the melanoma? Is you look at the, if for example this is the mole, and you check the symmetry. As you can see it over here, this the symmetry of this mole is This is a symmetrical mole. There is no asymmetry. Therefore, it is not the, we don't suspect that the patient is having any melanoma or it is not changing into melanoma. But if there is any asymmetry, okay, asymmetry with irregular border, and there is change in the color, which variety of colors may be present in a single mole. Some areas are lighter, some areas are darker, etc., where you need to suspect, yeah, this may be the case of melanoma. Then if the diameter is more or equal to 6 mm, again it is a case of suspected case of melanoma evolution. If it keeps on changing its shape or size, that is where we suspect that the patient can have melanoma. After that, we need to learn about uh, the different types of melanomas. One is lentigo maligna melanoma, which is also called as Hutchinson's melanocytic freckle. It is a slow growing and is seen most commonly in older people, usually who live outdoors or like work outdoors, like the farmers. And the most common site is head and neck. As you can see it over here, old people near the sun exposed area. Then we have the superficial spreading melanoma, SSM. It is the most common type of melanoma. Incidence rate is 70% in the individuals. Most common type of melanoma. And it first it spreads radically, then vertically. Shave biopsy should be done rather than the punch biopsy. Please remember that shave biopsy is more superior than the punch biopsy for the diagnosis and all. Then we have the nodular is the second most common type of melanoma, nodular melanoma. It's more aggressive and go deep. That means more it goes deeper, bad is the prognosis. So dermatoscopy is useless, of course. ABCD rule is not used for the nodular type because it is a nodular type, just like the basal cell carcinoma. But yeah, would not be any kind of, you would not see it. It would be nodular and blackish because it is melanin deposition. And of course, there won't be any telangiectasia or the pearly or beaded appearance, no roll edge appearance, no ulcerative formations, and of course, no bleeding and ulceration over there. So yeah, ABCD rule is not applied. Then we have the dermoplastic melanoma, which is very rare and looks like a scar, and it is mostly non-pigmented. Okay, non-pigment. We don't know the reason, but yeah, it is non-pigmented type of melanoma. Then we have acral lentigo melanoma. It is mostly seen in palm, soles, and distal phalanges. Please remember this acral lentigo melanoma seen in near the sites of palm, soles, distal phalanges. Any lesion which is seen at these areas, it is acral lentigo melanoma. Poor prognosis than others, and it is most commonly seen in the distal areas of limb. Then I remember one important point, and that is this one: nail apparatus melanoma. Okay, nail apparatus melanoma. It is a rare and fatal. It is also called as subungual melanoma. Please remember that you need to differentiate it from the subungual hematoma. That looks like the same, but subungual hematoma will include the most of the nail bed. Okay, but if you can see it over here, this is the late presentation of the nail apparatus melanoma. The initial presentation is seen as a longitudinal pigmented streak. So, any patient which comes at this very stage, you need to ask about the history of the initial lesion. If it was just like this, longitudinal pigmented streak, that is what is melanoma, nail apparatus melanoma. Later, then it from this longitudinal pigmented streak, it later goes to the proximal nail fold and becomes pigmented. That is what we call as Hutchinson sign. As you can see it over here, survival rate is it depends on the depth of the melanoma. That is what we call as Breslow's thickness. Okay, this is your MCQ in emetics. Then Uh, they ask a question about this sentinel lymph node biopsy. When do we go for the sentinel lymph node biopsy? There's a recall for that. When do we go for the sentinel lymph node biopsy in a patient who is having melanoma? Remember that if, for example, this is a patient of melanoma, there is a patient of melanoma, as you can see it over here. This is a patient of melanoma. Remember that if the thickness, okay, this is the thickness, the more it goes to the depth, poor is the prognosis. If the if the lesion is present over here, okay, the thickness, we went for the biopsy, okay, went for the biopsy, for example, we went for the biopsy, okay. Say for example the patient is having the lesion, the patient is having the melanoma and the depth is over here, okay, that means it is less than 1 mm, okay, less than 1 mm of depth. I will now take the biopsy. Let me take the biopsy. I took the biopsy and then check it, and once I check it, and if the thickness, if the depth is of this very lesion is less than 1 mm, there is no need of biopsy. But if the depth is, okay, more than 1 mm, I have to go for the biopsy. So that is your answer. That is your answer. Any patient whose melanoma thickness is more than 1 mm, we have to think about the sentinel lymph node biopsy. Then, what is the management? Excision biopsy with margin of 2 mm. Remember about the 3 to 5 mm for the squamous cell carcinoma and 3 to 4 for the basal cell carcinoma. And for the melanoma, we have to think about the 2 mm of thickness initially. Remember that this is the initial excision for it. This is basically for the diagnosis also, excisional biopsy with the margins of 2 mm. And then for the, it is used for the diagnosis initially and then for the further management also. Now, once we took the biopsy for the diagnosis, we diagnose it and we are now sure that yeah, this is a melanoma. We have to do the re-excision within 4 weeks, depending on the thickness involved by this melanoma. If it is still in situ, then we have to take the thickness of, further extend the excision to 5 to 10 mm. If it has thickness of less than 1 mm, we need to extend the excisional biopsy over uh, 1 centimeter. Then if it is 1 to 4 mm, we have to extend 1 centimeter, okay. And if it is 1 to 2 centimeters, basically over here, if the thickness is 1 to 4, if it is more than 4, we have to take a minimum biopsy of, extended biopsy of, uh, rather the extent, we have to extend the margins of more than 2 centimeters, but minimum should be 2 centimeters, okay. Minimum should be 2 centimeters. This is what you need to remember for the melanoma. Remember again, first for the melanoma, we go for the excisional biopsy with the margin of 2 mm. If it is diagnosed it as a melanoma, we do the re-excision within 4 weeks. Okay, 4 weeks. If the thickness of the initial biopsy was 5 to 10, if it was in situ, if it was still in situ, we will extend the thickness. We, after the second time, we will increase the or extend the excision, and we should be 5 to 10 mm. If it is less than 1 mm thickness, we will go and extend our excision to till 1 centimeter. If it is 1 to 4, then we will take it 1 centimeter to 2 centimeter. If it is more than 4 mm thickness, we'll increase the excision to 2 centimeters, as you can see it over here. Okay, 1 mm for the 1 mm thickness, for the less than 1 mm thickness, as you can see it over here. For less than 1 mm thickness, we will take it 1 centimeter. For those who have 1 to 4, less than 1 mm, go for 1 centimeter, right? For 1 to 4, we have to go for 1 to 2 centimeters. For more than 4 mm thickness, we have to go for 2 centimeter thickness. Then sometimes they ask about the follow-up. If it is a stage 1, we go for annually. Okay, we go for the follow-up. For any patient who is having melanoma, we go for a lifelong uh, follow-up. For the stage 1, we have to go for annually. For stage 2A, every 6 months for 2 years, then annually. For stage 2B and 2C, every 3 months for 2 years, and every 6 months in year 3, and then annually. These are the following are considered as the high risk of melanoma, and top one is those. If they ask you which of the following are, there's a patient who is asking for that what is the highest possible risk factor for the melanoma. The highest possible risk factor for the melanoma is the previous history of the, if the same patient had a previous history of melanoma, that is the highest risk factor for the melanoma. The following are considered at very high risk for melanoma: those with previous melanoma plus any of multiple atypical nevi, multiple previous melanomas, family history of melanoma, or there is a known carrier of high risk variant in CDKN2A gene. Okay, and there is another one if there is sun blistering due to the sun, rather skin blistering due to the sun. These are all important points about your none other than skin cancers. Okay, okay. Mm, yeah, sometimes they give you this query question. Just want to just give you a very brief idea about the dermatofibroma. This is also called as histocytoma or sclerosing hemangioma. And what is this? Basically, derma means skin, and fibroma means sclerosing. That means by fibroblast, there is proliferation of the fibroblast, which results in the sclerosing, right? Collagen deposition and all after minor trauma. If there is a minor trauma to the patient, like for example, a bee stings the patient, or there is a minor trauma, there will be a bump like this. That is what we call as dermatofibroma, which is due to the proliferation of fibroblasts, usually followed by the trauma or a bee sting, and it is zero point 0.5 to 1 mm elevation, and it may be pink or brownish or violaceous, as you can see it over here, and it is freely mobile. Okay, when it is pinched laterally, it shows a dimple sign, and lesion is most commonly asymptomatic, but it may sometime be itchy. Remember this. And see it over here. This is what we call as target sign lesions. Okay, target sign lesions. Remember that this is most commonly seen in herpes simplex virus. Okay, myoplasma patients who have a history of sore throat, or it can be due to the medications. Erythema marginatum, this is what we call as target lesions. These are symmetrical. Okay, and sometimes they involve the mucosa also, and they may be recurrent and persistent. Of course, symmetrical. Extensor surface, they may go to the extensor surface followed by centripetal involvement. And what is the treatment? You need to use the sorolim cream, that is basically your emollient. Okay, what is this? This is what we called as distal synovial cyst of the finger. This is sometimes there, it is painful. Remember this is painful, at the discomfort is present, which may differentiate it from the uh, which differentiates it from none other than pyogenic granuloma. As you can see it over here, these are pyogenic, this reddish appearance. This is what we called as pyogenic granuloma. But here, if you can see it over here, this is not reddish, and basically it's a mucus or synovial fluid which has accumulated over here, and it is painful and there is discomfort also, and it differentiates it from the pyogenic granuloma. It grows slowly and it is non-red and flashy like pyogenic granuloma. It presents medially or laterally and excise the lesion completely, otherwise they will recur. And as you can see it over here, this is pyogenic granuloma. Next step is to do the shave biopsy, and it is painless. And it is most commonly seen in those patients when there is sharp prick injury. Okay, and it is red and flush. This is red and flush. Remember this.